Hello everyone in Cardiomind's channel and welcome to the last video in the guidelines of Infective Endocarditis 2023, and we are speaking today about a famous and the common type of infective endocarditis, which is cardiac implantable electronic device related endocarditis. Let's remind ourselves with the modified Duke's criteria for 2023. First of all, major criteria: presence of a plaque culture positive for typical microorganism consistent with infective endocarditis from two separate plaque cultures, or microorganism consistent with infective endocarditis from continuously positive plaque culture, or single positive plaque culture, or elevated IgG antibody titer for Coxiella perneti, and imaging evidence either for presence of valvular, periprosthetic, perivalvular, foreign body material, anatomic or metabolic lesion characteristic of infective endocarditis detected by echo, cardiac CT, PET CT, or SPECT CT. And the minor criteria: presence of predisposing condition, fever more than 38 degrees centigrade, presence of embolic vascular complication either symptomatic or even asymptomatic, presence of immunological phenomena, or presence of microbiological evidence not fulfilling a major criterion. We consider the diagnosis a definite infective endocarditis if there are two major criteria, one major and at least three minor criteria, or five minor criteria, presence of possible infective endocarditis in case of one major criterion with one or two minor criteria, or 3 to 4 minor criteria alone without major criteria, and we reject the diagnosis in case of not meeting definite or possible infective endocarditis with or without alternative diagnosis. So now let's focus on the cardiac device related endocarditis. What is the accurate definition? It is an evidence of CIED infection with clinical signs of pocket infection and or imaging findings, so either one of them or both of them. Imaging finding in the form of lead vegetations or positive PET scan on the generator or the leads fulfilling the criteria for valvular endocarditis. So we can have signs of pocket infection or imaging finding or both of them. And the cardiac implantable electronic device include permanent single chamber or dual chamber pacemakers, implantable cardioverter defibrillator, or CRT device. We can classify these infections into two types: either localized infections that may be either superficial incisional infection, which is an acute infection occurring just after implantation without involvement of the pocket or the hardware, or isolated pocket infection but limited to the hardware in the pocket itself, or systemic infections that may occur with or without pocket infection, so there may be local signs of pocket infection or they may be absent, with or without visible vegetation on the tricuspid or pulmonary or pacing leads. So the presence of local signs of pocket infection or the vegetations are not a must to diagnose systemic infection on the device. The pathophysiology of this infection occurs by one of two mechanisms: either local infection from the bacterial flora on the patient's skin due to inadequate sterilization before implantation, and so they are introduced into the pocket at the time of incision despite surgical preparation. Example, the most common organism in this case is coagulase negative staph, or seeding via bacteremia from a distant septic focus, less frequent of course than the local infection etiology, and the most common organism in this case are Staph aureus and coagulase negative staph. The causative organisms that famously cause this type of infection, of course, Staph aureus and coagulase negative, the most common, enterococci, beta hemolytic streptococci and oral streptococci, Cutibacterium acne and cyanobacteria are from the microorganism reported to cause cardiac device infective endocarditis, and rarely to be caused by gram-negative bacteria or fungal infection in immunocompromised patients. If we speak about the risk factors to cause infection, we have multiple risk factors either related to the patients or factors related to the procedure itself. But we summarize them in the PADIT trial, which spoke about the most important 5 risk factors to increase the risk for infection. P standing for previous procedure on the same pocket. So is this patient having this procedure for the first time, or he had another procedure before on the same pocket? A standing for age, D standing for depressed renal function, I for immunocompromised state, and T for the type of procedure the patient is having. It randomized 19,603 patients undergoing implantation of a device to either conventional treatment with pre-procedure cefazoline infusion, just this, versus different regimens of incremental treatment including pre-procedure cefazoline plus vancomycin and intra-procedural bacitracine pocket wash and 2 days of post-procedural oral cephalexin, so a more complex antibiotic regimen. And the surprise that there was no significant difference between the two groups in the primary outcome of 1 year hospitalization for device infection, although we may expect that the second group may have much lower risk of device infection, but there was no significant difference from these additional measures. That's why a PADIT score calculator was created based on the PADIT trial that calculates subsequent rate of hospitalization for device infection by assessing, first of all, did this patient had a previous procedure on the same pocket or it is the first time? What is the age of the patient? The higher the age, the higher the risk of infection. Depressed renal function. As the more depressed renal function, the higher the risk of infection. Immunocompromised state, for example, receiving chemo or radiotherapy, reducing resistance to infection, or having a disease that impairs the suppression of infection, and type of procedure, as of course the risk is different. For example, it is the lowest risk with new pacemaker implantation and slightly higher with generator replacement, still higher with ICD, much higher with CRT as it is a more complex device and a more complex procedure needing prolonged time, and the pocket is opened for a longer time, and of course the highest risk with pockets or lead revision or system upgrade, for example upgrading from a single to dual chamber or from dual chamber to CRT-P or CRT-T. If you want to treat adequately cardiac device infection, you should focus on the prevention. First of all, you should think of preoperative antibiotic prophylaxis within 1 hour of the incision, covering Staph aureus plus minus MRSA according to the local policy of the hospital in which the procedure is performed. So we only give antibiotics just before the procedure. Either we're using flucloxacillin 1 to 2 gram IV or cefazoline, or if the patient is allergic to cephalosporins, we can use vancomycin or teicoplanin and clindamycin. And think of hygienic surgical environment and complete aseptic technique to reduce the risk of contamination of the pocket by the skin, flora, or by other aerosol infection in the operation room. Think of using of an antibacterial envelope that we are going to speak shortly about its dilemma. Proper post-operative care to reduce the risk of post-operative infection, and postponing the procedure in case of fever or any signs of infection. And avoid temporary pacing if possible. If the patient is presenting by AV block but he is vitally stable and he is kept in a monitored place, so we can avoid temporary pacing to reduce the risk of infection and arrange for permanent pacemaker as soon as possible. And of course, measures to prevent hematoma, because the hematoma is a very good medium for secondary infection. So whenever possible, stop antiplatelets if possible according to the last time of PCI. If the patient on warfarin, avoid bridging with parenteral anticoagulants, because bridging with anticoagulants increase the risk of hematoma. And of course, rinsing the pocket before closure with normal saline to clean any necrotic debris, reduce the risk of infection. So far, there is no evidence for these measures, like washing the pockets with antibiotics, like giving local gentamicin inside the pocket or putting flucloxacillin inside the pocket, and to administer antibiotics post-operatively. So far, there are no recommendations for these measures as recommended by the PADIT trial. There is some debate regarding the antibiotic mesh envelope. What about this? It is like a local antibiotic around the device that releases locally minocycline and rifampicin for a minimum of 7 days, and it is fully absorbed in 9 weeks. We're speaking here about nearly 2 months. And it may be useful to reduce the risk of infection in selected patients based on the rabbit trial, which showed that it significantly reduces the incidence of cardiac device infection in patients at increased risk, like for example undergoing a pocket revision or generator replacement, or undergoing system upgrade, or implanting CRT or ICD. So in this case, using an antibiotic mesh envelope significantly reduces the risk of infection, otherwise it is not needed. So let's revise the 2021 guidelines of cardiac pacing regarding the prevention of infection. Administration of preoperative antibiotic within 1 hour of skin incision had a class 1 recommendations to reduce the risk of infection, and using chlorhexidine alcohol for skin sterilization instead of povidone iodine should be considered as class 2A. And rinsing the device pocket with normal saline solution before closure is also essential to reduce the risk of infection. And the class 2B, to use an antibiotic eluting envelope, which is an antibiotic mesh, in case of patients having re-intervention CIED procedure, has a class 2B recommendation. And the big no in those guidelines that heparin bridging of anticoagulated patients on warfarin is not recommended. Keep the patients on warfarin on the lower range of the target INR and get the patient into the device implantation without stopping it. And of course, permanent pacemaker implantation is not recommended in feverish patients or patients having evidence of septic focus. It should be delayed until the patient is afebrile for at least 24 hours. Is there any change in the 2023 guidelines regarding the prevention? Still, antibiotic prophylaxis covering Staph aureus is indicated as a class 1, and using an antibiotic envelope still class 2B in selected high-risk patients undergoing cardiac device re-implantation to reduce the risk of infection. So it is not a routine measure, but selected in high-risk patients. An important question: if a patient with a cardiac device undergoing a dental procedure, does he or she need prophylactic antibiotics? So far, there is no evidence to recommend antibiotic prophylaxis before dental, respiratory, gastrointestinal, or genitourinary procedure because the risk here is very low. I know, of course, this measure is still adopted by many dentists and many cardiologists, but so far there is no evidence for this prevention measure. How can we diagnose cardiac device infection? Of course, the clinical presentation here is similar to valvular endocarditis, as the patient presents with fever and chills, and they may have embolic complications mostly on the lung, because here we are speaking about a right-sided infective endocarditis. Signs of pocket infection like swelling, tenderness, erythema, or purulent discharge may be present or may not be present in case of systemic infection, so do not depend on the presence of signs of pocket infection to confirm or exclude cardiac device-related endocarditis. Blood cultures is essential, of course, because the probability that there is a positive blood culture in a cardiac device recipient represents the underlying device infection depending on the type of organism and the duration of bacteremia. So it is not always positive. Sometimes it may be negative, and it should not exclude presence of a device infection according to the type of organism and presence or absence of bacteremia. The result will depend on this. And of course, suspicion of cardiac device infective endocarditis should be particularly high in the event of Staph aureus bacteremia, but less likely with gram-negative bacteremia, as it is not common to cause cardiac device infection, and in this case the pocket usually shows signs of infection. So we know that Staph aureus bacteremia is very dangerous on the device. Which imaging investigations will you order? Of course, combined transthoracic and transesophageal echo are both recommended, because transthoracic is not enough to visualize all the leads, especially the atrial and the CS leads, so vegetations may be missed. And of course, the pulmonary valve is not adequately visualized by the transthoracic echo, so transesophageal is essential. And if they are initially negative but there is a high clinical suspicion for infection, we can repeat them within 5 to 7 days. However, absence of vegetation does not exclude infective endocarditis, as sometimes the vegetation are present on the extracardiac segments of the lead. And sometimes in asymptomatic patients, you can perform a routine echo and visualizing some fibrinous lead masses. They do not predict infection and not related to infective endocarditis. So please do not diagnose infective endocarditis on the device just by visualizing these fibrinous mass. If the echo is inconclusive, so you can resort to PET-CT because it has better sensitivity and specificity, and so it is useful to confirm or exclude the diagnosis of cardiac device infection without signs of pocket infection. And be cautious that in the first 6 weeks, it may give you false positive results due to presence of inflammation and hyperemia at the site of the wounds. If there is no PET-CT available, you can ask for white blood cell SPECT CT, and don't forget that the cardiac device infective endocarditis is considered a right-sided infective endocarditis, so there is a risk for septic pulmonary complication, so whenever you suspect their occurrence, order CT chest. So the recommendations that transthoracic and transesophageal echo are both recommended in case of suspected cardiac device infective endocarditis to identify the vegetation, and you can repeat them within 5 to 7 days if they were initially negative but there is high clinical suspicion of infective endocarditis, and if you are still in suspicion, PET-CT may be considered in case of possible infective endocarditis to confirm the diagnosis. Let's go for the treatment. How are we going to treat this complex infection? We have two cornerstones: device extraction plus antibiotic treatment. You cannot use one of them and omit the other. Treatment of infection in this case include early and complete removal of all parts of the system. All the hardware should be removed, plus initial empirical antibiotic therapy directed at MRSA and gram-negative bacteria. And there is an exception. Sometimes complete device removal is not possible. For example, a patient had single or dual chamber pacemaker more than 10 years ago and using passive fixation lead. So extraction here is much more difficult than active fixation lead recently implanted. So in this case, you may fail to extract the whole lead. So use antibiotics for 4 to 6 weeks and having close follow-up after interruption of the antibiotics or long-term suppressive oral therapy, because in this case the hardware is still present, partially representing a risk for relapse or reinfection. Don't forget to obtain at least 3 sets of blood culture before the empirical antibiotic therapy covering MRSA and gram-negative bacteria to identify if there is bacteremia or not and what is the type of organism to modify your antibiotic therapy after the results appear. According to the recommendations of the task force, what are the indications for device extraction to be clear about this situation? First of all, class 1 indication for complete system extraction without delay in patients with definite cardiac device-related endocarditis under empirical antibiotic therapy. You should remove the device completely as much as you can. Percutaneous extraction is preferred to surgical extraction with lower risk, and it should be performed in centers and by personnel with expertise in this technique and with surgical backup due to a risk of tamponade or vein laceration during percutaneous extraction. And conservative treatment here alone is associated with increased mortality. So please don't think of just conservative treatment and telling yourself that I am giving this patient a chance to improve on antibiotics. No, if there is evidence of infection, complete system extraction is much recommended. The second indication is presence of valvular endocarditis even without definite lead involvement. Because, for example, if there is tricuspid valve endocarditis, the vegetation may colonize on the leads, but taking into your account the type of pathogen and requirement for valve surgery. This is a class 2A indication. And in case of gram-positive bacteremia or fungemia, complete system removal should be considered if they persist after a course of antibiotics, because here there is a high probability that the gram-positive bacteremia or fungi result in infection on the device. And the fourth indication, but with class 2B recommendation, that in case of gram-negative bacteremia, because it is less liable than the gram-positive bacteremia and fungemia to colonize the lead, complete system removal may be considered in case of persistent or relapsing bacteria after a course of antibiotics. Of course, lead extraction is a risky procedure, and so you should assess the procedure risk taking into account when did this patient had the leads implanted. The longer the time of the leads implanted, so the higher the risk and the more difficult the extraction. Whether the patient is pacemaker dependent, so he is needing temporary pacing or not. The patient frailty, sometimes the patient is too frail to perform device extraction, and presence or absence of comorbidities that assist in the decision making. Sometimes surgical extraction should be considered rather than percutaneous. For example, vegetation more than 20 millimeter. The percutaneous extraction here is associated with a high risk of embolic complications to the lung during extraction. Aspiration is not available or unsuccessful. The patient is still indicated for valve surgery. So for example, he has cardiac device infection plus tricuspid valve infective endocarditis that need replacement. And of course, don't forget that hardware retrieved from extraction should be sent to the cultures, especially the lead tip, to confirm the type of organism causing the infection. Regarding the duration of antibiotics, the standard is 4 to 6 weeks of antibiotics after extraction in case of presence of septic emboli or presence of prosthetic valves. But 2 weeks may be enough in case of non-staph aureus infective endocarditis without valve involvement, without vegetation, and the follow-up blood cultures are negative without septic emboli, so just 2 weeks of antibiotics after extraction are enough. The most difficult question: when to arrange for device reimplantation. So far, the quality of evidence regarding the timing of reimplantation is poor, so we don't have a clear answer. But the indication for reimplantation should be carefully evaluated at first. You should ask yourself, is the patient still indicated for pacemaker or for ICD or CRT implantation, or he is no longer indicated according to the guidelines of pacing or guidelines of ventricular arrhythmias? And be sure that no part of the removed CIED system reimplanted. So for example, don't sterilize the battery and put it on the other side. No, there is still a high risk for relapse or reinfection. And there are some conditions that you should follow during reimplantation. First of all, it should be performed at a site distant from the previous generator. So for example, if the pacemaker which was infected was on the left side, so reimplantation should be on the right side. Delay as much as you can until local and systemic infection resolve completely and blood cultures are negative for at least 72 hours after extraction. So don't rush for reimplantation. Be sure that there are no vegetations on the echo after extraction or any ghosts which are fibrous remnants after lead extraction, because they are associated with death and reinfection. And in case of presence of vegetation, you should wait for at least 2 weeks, not just 72 hours of negative blood cultures, to make sure that the patient is safe for reimplantation. What about if the patient is having ICD extraction but he is at high risk of sudden cardiac death? So I cannot leave the patient without ICD and I cannot reimplant the ICD as soon as possible to minimize the risk of reinfection on the new device. In this case, I can resort to wearable cardioverter defibrillator as a bridge to reimplantation. If the patient was pacemaker dependent, you can use an active fixation lead introduced via the internal jugular vein connected to an external pacemaker for up to 4 to 6 weeks and on the same side of the extracted battery, because you are aiming to preserve the contralateral side for definitive reimplantation. There are some alternatives to delayed reimplantation. For example, an epicardial pacemaker may be implanted surgically before lead extraction. This is in case that you had surgical extraction of the device. But beware that this strategy has been associated with a higher risk of device reintervention. And other options are using leadless pacemaker or subcutaneous ICD in selected patients if the risk of new infection is still high. So, the recommendations for the device reimplantation after extraction has some condition to be performed at a site distant from the previous generator as late as possible, waiting till signs and symptoms of infection resolve until blood cultures are negative for at least 72 hours in absence of vegetation, or at least 2 weeks in case of presence of vegetations. And the big no in this task force that removal of the device after just a single post-blood culture is not indicated if the patient has no other clinical evidence of infection based on the symptoms, signs of local pocket infection, presence of vegetation, using PET scan. All of these should be used in order to confirm or exclude presence of cardiac device infection do not depend on just single positive plaque culture to perform unnecessary device extraction. At last, this diagram summarizes how to manage a patient with cardiac implantable electronic device related infective endocarditis. Of course, withdraw 3 plaque cultures, arrange for transthoracic and transesophageal echo, and in some cases you may arrange for PET-CT or SPECT-CT. Then use the modified Duke's criteria. If the patient has definite infective endocarditis, so start antibiotic therapy covering MRSA and gram-negative bacteria. And if there is evidence of definite cardiac device involvement, class 1 to perform device extraction with complete hardware removal. If it was just a possible infective endocarditis, you should repeat the echo and the plaque cultures within 7 days. If there is no evidence of infective endocarditis, so it is a rejected diagnosis. But if there is evidence of bacteremia or fungemia without other major criteria or source of infection, you should start antimicrobial therapy. Either the patient will be cured, but sometimes the patient may have persistent or relapsing bacteremia or fungemia. If there is evidence of gram-positive or fungemia, so there is a high probability to infect the device, so there is class 2A for device extraction. If it is just a gram-negative bacteremia, so there is less probability to infect the device, so it is class 2B evidence for device extraction. Then after extraction, if there is evidence of septic emboli or presence of prostatic valve, so 6 weeks are essential of antibiotic therapy. If there is evidence of vegetations and or Staph aureus infection, so 4 weeks of antibiotic therapy are essential. If there are no evidence of vegetation or non-Staph aureus infection, so just 2 weeks of antibiotics after extraction are enough. And then arrange for device reimplantation according to the conditions that we mentioned before. So we have reached the end of this video discussing the management of cardiac device infective endocarditis. The main take-home message: that prevention is a cornerstone. Don't wait till infection occurs and then start treatment. You should pay attention during and before implantation for preventive measures, and device extraction is always essential before antibiotic treatment, because here you cannot keep the hardware and keep just on conservative treatment, high risk and higher mortality. So always device extraction is essential with very minimal exception. Thank you very much for watching the last video in the guidelines of infective endocarditis, and shortly we are going to discuss new guidelines of 2023. I am waiting for your comments to tell me what were your opinions regarding these videos and any other modifications or comments that you want me to apply for these guidelines or in the next guidelines we are going to explain.